the topic, and I congratulate, first of all, I would like to congratulate the Department of Medical Oncology and the entire Uro-Oncology DMG for taking this initiative, bringing up this very pertinent topic on this forum, and I hope this will be of much of benefit to all the audience who are present here. And I see the recording is also going on, so maybe it will be beneficial for the audience who will be witnessing it, say, on the line. So, say in this, my job has been made much easier by Dr. S.N. Singh. He has, outlined. He has given the introduction of the staging part, which is very important in the bladder cancer, as well as the muscle invasive and non-muscle invasive. So the same things I am also going to deal with, though in a brief manner, and then I'll come to the different histological types of urothelial cancers. Is it whether it is invasive or non-invasive, that all things we are going to see. And then there are certain rarer variants like squamous cell carcinoma, adenocarcinoma and small cell carcinoma, etc. So this is the normal anatomy of the urinary bladder. One can see over here that this part is the urothelium. This urothelium, it is 3 to 7 cell, 5 to 7 or 3 to 7 cell layer thick, and then beneath it is the lamina propria. So there is a subepithelial connective tissue where you can see blood vessels, you can see mild lymphocytic infiltrates, and this is limited by the muscularis mucosa or muscularis. This is a wispy layer which is kind of non-continuous in nature, and beneath this muscularis layer is the muscularis propria. So this muscularis propria invasion, as we were seeing, so that was the debate, a point of debate from the oncology perspective, whether the tumor is involving the muscle layer or not. So this is the layer which is also known as the detrusor layer. So this comment on this particular layer is very important in the histopathology report. And then beyond this is the adventitia or serosa. So this part has been very well dealt by Dr. S.N. Singh in radiology, in his radiological talk. So same thing is here. So then we have the TA lesion, which is the non-invasive papillary carcinoma. So the lesion is confined to the overlying epithelium only, and it does not goes into the lamina propria. Then we have in situ, carcinoma in situ, so it involves the full thickness of the urothelial lining. Then we have T1 lesions. So the T1 lesions, so there is invasion of lamina propria. So this is the lamina propria, and the tumor, it goes into the lamina propria, and it is classified as T1. And then we have T2. So T2 is further subcategorized into T2A and T2B. So the inner half of this muscle layer, if there is invasion, so then the lesion is termed as T2A, and then when it is involving the deeper half, it is called as the T2B. And then we have T3 lesions, the lesions which is involving into the perivesical fat beyond the muscularis propria, and T4A and T4B lesions, the lesions which is involving the adjacent organs. Say for example, the bladder cancer involving the prostate would be categorized into T4A lesions along with seminal vesicles, uterus and vagina, and if it is involving the pelvic or abdominal wall, it will be T4B lesions. So what is the importance of this pathological staging? So we have to, as we were discussing, we have to see whether the tumor, whether it is involving the muscle or not. If it is involving the muscle, so whether it is confined to the muscle or going beyond, because the prognosis of the patient is dependent on this. And not only the prognosis, the therapeutic modality is also important, because whether to go for the organ preservation or go for radical surgeries vis-a-vis radiation therapy or chemotherapy, so that call has to be taken based on the T stage of the tumor. So let's see the lamina propria invasion. The first thing, the lamina propria invasion. So whenever we receive biopsy, so it is very difficult at times to comment on the lamina propria invasion. The reason being because we get biopsy in bits and pieces. So the biopsy is number one, fragmented. Number two, there might be some pottery induced artifacts. So that again prevents us to exactly comment upon the lamina propria invasion. and there is of course a poor orientation, so that we can tackle. Say for example, if we are seeing biopsy on one plane, so we may ask our technician to rotate it to the 90-degree, and then we can see whether the lamina propria is invaded or not. So this is the thing. But then when we see in histology some urothelial nest, the clusters and single cells, so it becomes easier for us to identify lamina propria invasion. But then again, these findings are very rare. So most of the times we struggle to identify whether the lamina propria is invaded or it's not. So these are some features of lamina propria invasion, where we can see these nest of the cells infiltrating the lamina propria. There might be some single cells as well, as you can see over here in this photograph. Then the muscularis propria invasion. The muscularis propria invasion, see here we can see this is the detrusor muscle, the pink part, and then the more bluish part is the part of this tumor which is infiltrating the muscle layer. Then the perivesical fat infiltration. So the perivesical fat infiltration is again because it will upstage the tumor, and here we can see these nests of the tumor which are infiltrating into the adipose tissue. Now one word of caution over here for the pathology people, that perivesical fat, even if it is identified in the biopsy, one has to be very sure that it is actually from the perivesical fat. Because what happens that the fat can also be seen, say between the muscle layers, and sometimes even in the lamina propria. So merely if it is infiltration of fat in the biopsy, so one should not jump to the conclusion that it is the higher stage disease. Now this has been discussed in detail, but again from pathology point of view, I would like to highlight certain points, that whether the muscularis propria. So in our pathology report we have to comment, number one, whether the muscularis propria is present or not, and number two, if it is present, so whether it is involved or not. So these are the two comments, and very vital comments, which should be part of say every histopathology report, and the implications of which we have already seen and discussed. Then one more important finding which should be part of our routine histopathology is the presence of vascular invasion. So you can see here, this is the blood vessel, and within this are the tumor emboli. So this thing, sometimes it is difficult to establish, because the tumor, urothelial carcinomas, though they present with a retraction artifact. So retraction artifact is nothing but the stroma and the tumor. So there is gap between the two because of the retraction thing. So this retraction artifact has to be distinguished from the true vascular invasion. So if it is difficult to identify, we may take help of the immunohistochemistry, where say the endothelial markers like CD34, CD31, they may help us in identifying the vascular invasion. Then this is the normal urothelium, say which is say 3 to 7 cell layer thick, and say with this, if we go onto the top in the sense ki we go from the base layers to the luminal side of the bladder. So there is umbrella cell layer, which is the topmost layer over here, and identification of this layer is important in distinguishing whether it is a carcinoma in situ or merely a dysplasia, which we will see in subsequent slides. So the urothelial lesions, so they are non-invasive urothelial neoplasms, as well as there are invasive urothelial carcinomas. So we will see all these lesions say one by one. So these flat lesions or dysplasia or atypia, so this is the first category which I am going to discuss. So these are basically the atypical changes, and these atypical changes, they fall short of calling it carcinoma in situ. So in carcinoma in situ, as I have told you, it will involve up to the umbrella cell layer, whereas this atypia or dysplasia, they will not be involving the umbrella cell layer. So this is the basic difference between dysplasia, atypia or carcinoma in situ. So these areas of dysplasia, it may be seen in almost all cases of invasive bladder cancer, and primary dysplasia without carcinoma in situ, it is predominantly seen in middle-aged patients with the presence of symptoms of like bladder irritation or with or without hematuria. So this is the dysplasia. One can see over here, this is the dysplastic lesions in the urothelium. Now in the dysplasia, the layers of the urothelium, either it can be increased or it can be reduced. But the important thing is The important thing is this preservation of the umbrella cell layer, as you can see here. This is the cystoscopic view of the bladder lesion. So this is basically seen in carcinoma in situ, where one can see the hyperemic and nodular appearance of the mucosa as well as the tortuosity of the blood vessels. Now carcinoma in situ is a lesion higher than the dysplasia, where the dysplastic changes are involving entire thickness of the urothelial layers. So this is the carcinoma in situ, where one can find the entire thickness of the urothelium is involved, and it is associated with the cell's morphology. If we talk about it, we'll say severe nuclear pleomorphism. We can see at abnormal mitotic figures over here, and importantly, all the layers of the urothelium is involved. Then there are benign lesions. Now these benign lesions, they are treacherous in the sense that at times it becomes very important for us to comment whether it is papilloma, urothelial papilloma, or low-grade papillary urothelial carcinoma. So in urothelial papilloma, one can identify a discrete finger-like projections, as we can see it here, and these are simple non-branching papillae. Papillae, we all understand, it's a fibrovascular core and it is surrounded by the epithelial layers. Then there is inverted urothelial papilloma. So this inverted urothelial papilloma is important because when the papilloma goes inside in the lamina propria, so it becomes important for histopathologists to distinguish whether it's an invasive carcinoma, low-grade invasive carcinoma, or inverted urothelial papilloma. So because the treatment implications would be different, I guess. Then there is one entity which is called as the punlum, or papillary urothelial neoplasia of low malignant potential. So say it is also showing, it will also show the papillary fronts, but then there will be more of a cellular crowding, as we can see here. So as if we compare with the low grade the papillary papilloma, urothelial papilloma, there will be more increased density of cell layers. Then there is non-invasive low-grade papillary urothelial carcinoma. So as the term suggests, it's non-invasive, that is, it is confined to the urothelium itself, but then we can identify the fused appearance of the papillae. So in urothelial papilloma there were discrete papillae, whereas in this low-grade papillary urothelial carcinoma there will be fused papillae, and but then this fuse the fusing will be minimal, it will not be widespread, and cytological atypia will not be there. Then there is non-invasive high-grade papillary urothelial carcinoma. So again here the lesion is confined to the urothelium, but then it is accompanied by a very severe atypia, and the papillae, they will be more diffuse. They will be diffuse in appearance, where the papillae will be fused in a more diffuse manner. Then coming to invasive urothelial carcinoma. Now coming to this entity, so in recent 2022 WHO classification, earlier we were using the term histological variants. So now the term variant has been replaced by the histological subtype. So we have nested subtype, we have large nested subtype, tubular and microcystic subtype, micropapillary subtype, then lymphoepithelioma-like subtype, plasmacytoid subtype, and sarcomatoid subtype. So these are some important histological subtypes of urothelial carcinoma. Why it is important to know all these categories, that we will see in the subsequent slides. But the one thing is that, say, if we identify these specific subtypes, so some of these specific subtypes are associated with say for example HER2 mutation. So if HER2 mutation is there, so then we have targeted therapy against the HER2, that is the trastuzumab and then the other related medicines. Same way there are urothelial carcinomas where there is PD-L1 is say expressed in those. So then we can utilize the targeted therapies against PD-L1 in those histological subtypes. So this is the importance of identifying these various histological subtypes of urothelial carcinoma, so as to offer the related treatment. We will see, and then there is divergent differentiation. So divergent differentiation is the urothelial carcinoma with either squamous or glandular or trophoblastic divergent differentiation. So that that is the divergent differentiation again has to be differentiated from the other, histological types. Say for example, squamous differentiation needs to be distinguished from the squamous cell carcinoma of bladder, which is very rare, primary squamous cell carcinoma. Then, as I have told, this WHO has recently deleted the term, replaced the term variant from this subtype, and the subtypes. So, the treatment wise, it is very important to know what are the various subtypes. Now, the nested subtype. The nested subtype, histologically, it will appear a bland tumor, but the tumor is very aggressive in nature. It has got a deceptively bland appearance, and it will say look as if the von Brun's nets, they are infiltrating the lamina propria. But as we go deeper, say in the lesion, if we go deeper in the sense, say the muscle invasion is there. So if we go deeper into the muscular layer, so this will show its the true character, in the sense, the severe atypia, the other atypical changes, we will be able to identify more in the deeper layers. So this is a nested subtype of urothelial carcinoma, where nests are the closed groups of cells over here, as we can see, and then there is some infiltration of lymphocytes and plasma cells as well. The second subtype is the tubular and microcystic subtype. So in tubular and microcystic subtype, we can see tubules and microcysts, and these microcysts, they will have secretions within. So say these earlier these two lesions, nested microcystic subtypes, so they don't have specific therapies against them, but then micropapillary subtype. So this is the important subtype of urothelial carcinoma, where we can see micropapillae, that means a papillae without any fibrovascular core in a true sense, and then it may have necrosis. So this is the subtype I was talking about. It will show the activating extracellular domain HER2 mutation. So this HER2 mutation is say if we demonstrate it on immunohistochemistry in this particular subtype, then we have therapy against this particular micropapillary subtype. And by definition, micropapillary subtype is the subtype of urothelial carcinoma where at least 10% of the cells, the tumor cells, they should show this kind of morphology. Then the other subtype is the lymphoepithelioma-like subtype. So this lymphoepithelioma-like subtype, so we are aware of this terminology in nasopharyngeal carcinoma, where it is associated with EBV virus. But then this subtype is not associated with EBV virus either by IHC or by in situ hybridization. But the important thing is that this is responsive to chemotherapy, and it will show PD-L1 expression. So if this subtype is identified, and if we order PD-L1 and if it is positive, we may offer therapy, the checkpoint inhibitor immunotherapy against this subtype. Same is this plasmacytoid subtype. This plasmacytoid subtype is of urothelial carcinoma. We can see the cords and nests of these cells, and then cells will have plasmacytoid appearance. So plasmacytoid appearance, what do we mean by it? So plasma cells have a eccentric nucleus. So same way, if any tumor is showing plasmacytoid subtype, it will show a nucleus which is more eccentrically placed, and it will have abundant cytoplasm. This plasmacytoid subtype, again, how will we identify it's a plasmacytoid type of urothelial carcinoma, especially in biopsy? So plasmacytoid subtype is identified by its plasmacytoid appearance, number one. Number two, if we put immunohistochemistry, it will show IHC markers for plasma cells as well as for the urothelial markers like GATA3. So it will be positive for CD138 as well as for GATA3. And the important pathogenesis of this subtype is that it will show loss of CDH1 gene. So CDH1 gene loss, as we all know, we see in the lobular breast carcinoma as well as in gastric carcinoma of diffuse type. Same way, this plasmacytoid subtype of urothelial carcinoma will show CDH1 gene mutation, and this is highlighted by the loss of E cadherin on immunohistochemistry. So this is the third marker which can identify this subtype. So the last is the sarcomatoid subtype. So sarcomatoid subtype of urothelial carcinoma, it's a biphasic tumor where we can see the epithelial as well as the mesenchymal markers, either by either we can see it on histology or by IHC markers, and it will have a very poor prognosis. Again, it will show again increased PD-L1 expression. So if the histology report, if we identify sarcomatoid subtype, so again PD-L1, if we do it, if it shows expression, we can offer immune checkpoint inhibitor therapy in this subtype as well. So sarcomatoid subtype and lymphoepithelioma like subtype will show PD-L1 expression. The micropapillary type will show HER2 mutation, and these are the various subtypes, and then we have divergent differentiation. So this is a urothelial carcinoma with squamous areas, which we can see here. So again, this is important for pathologists to identify whether it's a squamous differentiation or squamous cell carcinoma. So that call has to be taken by pathologists. Same way we can have a divergent glandular differentiation. Again, this is a adenocarcinoma and urothelial carcinoma with the glandular differentiation, which we can see here. So in other areas of this particular lesion, we may identify a typical urothelial carcinoma, and then there are markers which are positive like CK7, CK20 and GATA3. Other rarer histologies are squamous cell carcinomas, adenocarcinoma, small cell carcinomas and metastatic tumors. So squamous cell carcinoma, as I have told, the primary squamous cell carcinoma bladder is very rare, and one has to actually distinguish whether it's a squamous cell carcinoma or squamous differentiation, which is a very known phenomena in a high-grade urothelial carcinoma. Adenocarcinoma, again, it can be of two types, the urachal origin and urachal in origin. And small cell carcinoma, it will mimic any neuroendocrine carcinoma, so it will show markers which are positive for neuroendocrine cells like CD56, synaptophysin. And important thing is that 1/3 of these tumors, they will also show TTF1 positivity, the small cell carcinomas of the bladder. So again, one has to be very particular about these markers, because at times when we see metastatic sites and if we are not aware that the lesion is in the bladder, so it may mistakenly be given as that either it is arising from the lung or the other sides. Then there are metastatic tumors. So mostly metastatic tumors in the bladder, they are rarer, but then if at all they will be seen. So it is basically an extension from the adjacent organs, like say prostate cancer, which may be mistaken for the bladder cancer. So these are the histology and then the pathology perspective of bladder cancer. I think I am well in time, Dr. Akhil.
Yes, sir. Thank you, sir. Thank you so much. There are some questions actually.
Yes.
Establish the utility of EMVI as a biomarker for aggressiveness in rectal cancers. So, in case you do not see extravesical fat space involvement, this problem is occurring even in VIRATs. So, between VIRATs 4 and 5, sometimes we might upstage and downstage accordingly. So if you see EMVI positivity, but no extravesical fat space involvement, so how do you label it? Will you call it serosal involvement, and how does it affect the management?
Yeah, so basically see, this problem will be addressed here or maybe sometimes in the lamina propria layer. So this is for the pathologists to, we should not interpret the finding ki if there is a presence of fat, there is infiltration, so it need not necessarily that it's going beyond muscle into the perivesical fat. But but if we get to see cystectomy specimen, there we can very surely tell you ki whether the fat involvement, it is it's beyond the bladder or within the bladder.
Thank you, sir. So, as you highlighted, there are bladder cancer, though it is not in the routine practice till now, but I think the points which you have highlighted are very, very important. For example, HER2 mutation. We know that wherever HER2 mutation is there, the outcomes are bad if HER2 targeted therapy is not given. Similarly, we have found this, we are doing even androgen receptor AR-IHC also in bladder cancers now. So, we know that androgen receptor expression, we have a treatment available. That is why we are running a study where if androgen receptor IHC is positive, we are adding enzalutamide to the treatment versus placebo. So this study is already going in our setup as well. So yes, with time we understand that apart from chemotherapy, we need definitely much more agents which can control the disease, and also it will be tailored according to the disease biology, because every tumor is different and we need to identify the problem with this. Thank you, sir.
We will have the NGS